Tatiana, you are going to accept just to focus on the horizontal injection. Yes. So please explain, go step by step, make some drawing and concerning the analysis of the patient, and then, of course, we are going to follow your injections.
Okay. Thank you very much, Benjamin. Thank you. It's my great pleasure and honor to be a part of this cadaver workshop that I think it's very essential for every doctor who is doing injections, doesn't matter if plastic surgeons or dermatologists. I have actually the same patient like Marina had, but I just have her right side. And my side is maybe a little bit better looking or a little bit less atrophic than Marina's side. What we see in her, I just can repeat once again, maybe you can see it when we have a closer view here, that her lateral sousp is actually in a pretty good shape. So I'm not going to inject here. I'm going to concentrate on the horizontal approach. So I'm going to use blunt tip cannula. And when I speak about blunt tip cannula, I think actually 22G cannula. If you have a 27 or 30G cannula, for me, this is not a blunt tip cannula because you can injure the vessels with these very small cannulas. And I prefer to use a longer one just to be more flexible. What is very important when you look at the patient and using a cannula, that we do not inject the material, the whole material into the superficial fat pads. So what I'm going to do actually in her, because she's having this atrophy, and we see here the nasojugal groove, and in the prolongation, the palpebral groove. This is the nasojugal groove, and we see in the prolongation palpebral groove. And actually, when I look here at the shape of the zygomatic arch of the cheek, we see there is a very nice high cheekbone here. So as a woman, she knows where to apply the brush, but what we see is the atrophy here in the deep, what Marina also explained, in the deep medial cheek fat pad, and maybe a bit, I would say, also into the medial sousp. What we have to avoid definitely when we're using a cannula, because I am a big fan of cannula, but some colleagues, they say they can't be as precise with the cannula as with the needle, not to inject into the superficial nasolabial fat pad here, because this would even exaggerate the appearance of the nasolabial folds and a patient would just look puffy. So I'm going to inject from more or less medial approach, just going a little bit laterally here, far away from the facial artery, because this is always we have to take care. With the cannula, I have a lower risk to injury the angular artery and all the other arteries than with the needle. And what I have to do, and this is what I'm going to do now, when we're injecting with the cannula, is to take care that we go through this mess, so that we really achieve the deep facial fat compartments. I did a small pre-incision here. I hope I can see it, because my marcation line was red as well. So this was a 21G needle. This is, I'm using the same product because of the patient needs, like Marina. It would also be possible from the same range from MFL to use MFL volume or some other, but I also prefer deep because it's a little bit more gentle to mold and it has a high G prime. Take care that you're not touching the tip of the cannula. And you see when I'm coming now,
okay,
there is a resistance.
Stay like that,
so
stay like that, okay. Tatiana. Yep. Don't move. No. And Fabio, could you show in details on the cadaver, where is Tatiana?
You can't see it because it is inside the sousp. It is here. You see the tip of the cannula here, but it is inside the sousp, so it slides in contact with the bone.
Okay, so we see the movement and we see exactly where you are. So now, Tatiana, you can keep on your explanation. So, and you see here, if I would start to inject here, not move forward, I would be exactly in the superficial between the medial and the middle cheek fat pad. So I have to pinch the skin with the cannula and then push and go through the SMAS and then come into the contact with the bone and taking care where is the tip of my cannula. And now you see where Fabio was exactly here is also the tip of my cannula. So into the medial sousp. Injecting slowly and then staying into the contact with the bone. I'm someone who, with the deep fat pad, rather prefers to inject in a small pearls, just to have a little bit higher contact. And here, in the deep
cheek fat pad, I go again through this mesh, but almost perpendicular with the cannula, but it's still a cannula, and inject another small portions. And what Fabio, that was the deep, and if I want to inject into the superficial fat pad, I retrace my cannula and then go actually into the superficial fat pad. Can you turn to your face? Yeah.
Tatiana, there is always the question, actually.
And then I would, Marina, just to finish the sentence.
Okay.
Then I would inject, as you have very nicely explained, we have also in the superficial fat pad the inferior migration in the compartment itself. So if we inject there something to redistribute the fat again, we should only inject into the superficial part of, into the upper part of the superficial fat pad.
So the question with cannulas, actually, how much superficial can you be with the cannula? Because there is always a question about the plane of injection. So the most superficial plane that you can inject with cannula is?
It's directly scratching on the bottom of the dermis.
Good. So superficial fat compartment is actually your target tissue.
Yes. Or depends on the product I'm using. Sometimes I really try to scratch on the dermis in order to increase the collagenesis effect. So it's rather for the tightening purposes and not for the volumetry, really.
Okay, Tatiana, the big question, of course, we need to debate with the audience and Marina, is it a real concept, the fat compartment? Meaning, is it something with absolutely something we need to respect? Or have we just to take care about the different level of the fat, that's it? So what is your opinion, Tatiana?
I believe that's important to understand the concept of the fat compartments because, I mean, if I would now inject, everyone speak about SOOF injection, and in most of the patients this is correct, but why to inject the SOOF in her lateral SOOF? It's not necessary. So I have to concentrate on the compartments that are more atrophic. It's not the same in every patient. I mean, there are some patients, everything is atrophic, so you can inject wherever you like. But in the most cases, it's a really sensitive decision where to inject more and where to inject less. And we all have seen the cases of the patient that have been injected with, let's say, 80% of the product or all the product in the superficial fat compartments. And then they develop these puffy eyes, a puffy face, and have more edema, and the face does not really look more attractive because this even increased the sagging. So the apex of the cheek is not where it should be, like Marina marked over there, or as you see here in the patient when I speak about the blushing line in the woman, but it's rather somewhere further down and increase the appearance of the nasolabial fold. And then they have to be injected again into the nasolabial folds and they look like monkeys.
Yes, I completely agree with you that it's a concept that we have to understand. It gives us better understanding of the aging process. The pseudoptosis, I think it's a major thing about, especially about the mid face, and but we have to individualize the treatment according to patient. I think that another important issue that has been so nicely visualized by our anatomist, because from a single injection point, because the fat is actually compartmentized, the filler will disperse, will take place of all the compartment. You don't have to have multiple injections, and it will not diffuse further on because there are membranes that are catching it.
So it's like a spreading.
Yes, spreading, controlled spreading.
Controlled spreading.
Yes. Yes,
okay.
So this is nice about the fat
Okay, so Fabio, we would like your conclusion about this part dedicated to the fat compartment, and then I know that you will change to another subject. So please, Fabio, could you conclude?
I think that both techniques, knowing where the septa are and knowing the topography of the fat compartment are useful. Because going from down and also using a cannula, the traumatism on the septa is really low. And a needle with a bolus technique, knowing where to inject, it means injecting in the center of each compartment, create a really small traumatism to the septa and ligaments.
Okay, Fabio, so thanks a lot for this wonderful explanation.